So welcome back to the Urology Care podcast. I am going to let my guest introduce herself right now.
Hello, my name is Veronica Triaca. I'm a physician. I practice in Concord, New Hampshire, and my specialty is female pelvic medicine and reconstructive surgery.
So today we're going to be specifically talking on the topic of interstitial cystitis. So I'm going to open the discussion up with just asking, what exactly is interstitial cystitis? Can you please just describe it?
So interstitial cystitis is a variety of symptoms that include urinary urgency and frequency and very often bladder pain. All of those symptoms don't necessarily have to be present for the patient to have interstitial cystitis. Sometimes we can have very extreme symptoms like blood in the urine and recurrent symptoms that can be cyclical. But definitely the mainstay of IC patients, there's some component of pain and some component of needing to go to the bathroom frequently and urgently.
When you say cyclical, do you mean the symptoms come back and return when they may have thought you've gone away?
So, most patients with IC will have and experience sort of a chronic condition, chronic symptoms that can wax and wane, and very often patients can describe a flare in symptoms that is periodic. Sometimes it's predictable, sometimes it's not, but certainly it is not a constant presentation all the time. So patients can experience periods of relative health and symptom-free.
Do we know what some of the root causes are?
There's a lot of assumptions, but I think to make it fairly simple, and I know the science behind the disease is fairly complex, so we're not sure as to why patients get this, and there are a variety of theories as to why some patients are more at risk, but bottom line, we don't know.
How would one know that they have it, or they might suspect they have it? What kind of symptoms would they be feeling?
So some of the most common symptoms are frequency and urgency associated with some form of bladder pain. It is a diagnosis that should be given by a urologist, and that's most of the patients that I see often will come up with a diagnosis already, but I believe that for you to really know, you would have to have been evaluated by a urologist.
I'm not sure there is an answer to this question, but I'll ask it anyways. How can interstitial cystitis be prevented?
I think the only time you can be sure that prevention is an option in a disease state is to know its root causes, and given the absence of that knowledge, I don't think we can prevent IC. We can manage the condition once we have that diagnosis, but I don't believe it can be prevented.
Do you want to just discuss some of the different treatment options that might be available?
Sure. The AUA has come up with some guidelines for treatment, diagnosis and treatment of this condition. There are very simple treatment options that relate to what we call behavioral changes and the avoidance of dietary irritants, for example, caffeine or other dietary substances that can exacerbate symptoms. There are IC diets that folks can follow. There's a lot of treatment options that are directed towards the symptoms. For example, if you have severe urgency and frequency, we can certainly treat that particular symptom. The diagnosis of IC is critical because if a patient is suspected of having IC, they do go through an evaluation, and part of the evaluation may include an evaluation of the bladder, looking inside the bladder, and if an ulcer is noted within the bladder, a treatment option would be to treat that ulcer. So there are varied treatment options, and one thing that is important, though, to understand that IC never really exists alone. A lot of patients with IC will also have conditions that are associated with their bowels. They have a lot of irritability in their bowels, maybe even some menstrual dysfunction such as endometriosis, and so it is important to kind of treat the whole patient and not just the bladder symptoms. And very often in my patient population I will assess those other areas, because if a young woman with endometriosis has bladder symptoms and her endometriosis is not well treated, we make no progress in treating her bladder symptoms. So I think part of it is to understand that the disease itself is very complex.
That makes perfect sense. And I just want to chime in and say, if you please excuse the background noise, we're actually recording this at a section meeting of the AUA. You were so kind to join us, and I want to thank you for that and excuse any of the background noise going on. I just want to also touch more on the diet advice. Is there any more tips you can give on what are some maybe bladder-friendly foods, what are some non-friendly bladder foods, or does it just depend on the patient?
Well, I think it mostly depends on the patient. I think the IC Society does run a website, and the ichelp.org website has a very inclusive, exhaustive diet listed. However, it is very much dependent on the patient, so there are very classic things that I will recommend to my patients to avoid. For example, caffeine. And I usually use the 4C mnemonic: caffeine, citrus, very cold drinks, and carbonated drinks. But that can encompass a whole list of things. So I generally ask patients to consider an elimination diet. They might try avoiding caffeine, avoiding citrus, avoiding those kinds of things for a while, and then slowly reintroducing them to see if their symptoms flare. Unfortunately, again, going back to the complexity of this condition, there isn't one thing that's going to make the patient better, and it does absolutely vary patient to patient.
Do you have any other final thoughts on this condition before we wrap up our discussion today?
So I think from my standpoint, I treat a lot of patients with a diagnosis of IC, and very often, even though we assume it's a common condition and that a lot of women who have these symptoms by default have IC, I want to stress the importance of treating the whole patient. So in my clinic, patients are evaluated by a gynecologist, and the treatment ranges from assessment of their menstrual cycle, hormonal management, as well as dietary, but very often behavioral and psychological interventions, because this condition can be so incredibly disruptive to a patient's life that unless you take that into consideration, you're really not improving the patient's quality of life. And I think overall, it would be doing a patient a disservice if you didn't consider the complexity of these symptoms and this condition, and therefore you just be very tunnel visioned in your treatment.
Do you see men with this condition at all?
It's less common, but definitely there are men with this condition. There are probably significantly more women than there are men, but certainly it is seen in men as well.
Is there anything that might be different if you have it in a man? Is there any other thing you want to touch on regarding gender in IC?
I think the criteria for diagnosis is exactly the same, and I think the treatment options are exactly the same. However, men don't have a cyclical component such as period or hormonal factors as much, although there's probably some element of that we just don't understand just yet. It's a lot easier to figure that out in a younger patient who has regular menses or irregular menses. Having said that, though, the patient with IC is a very unique patient, be they either female or male.
Now, I just want to have you one last time remind us who you are and where you actually practice.
My name is Veronica Triaca. I practice in Concord, New Hampshire, at Concord Hospital.
Thank you so much.
Thank you.
This podcast has been brought to you by the Urology Care Foundation, the official foundation of the American Urological Association. For more information on today's topic and for all things urology health, visit urologyhealth.org.